And bring my phone when you're done.
Okay, so welcome everybody to the webinar. We are going to talk today about the gastrointestinal physiology. And for that, I provide the PowerPoint, so I hope that it was very well organized in order to follow this webinar. So let's start. So what we have here in the screen right now is just I found a video about the pathway of the GI tract from the mouth to the anus. So they are going to just to illustrate a little bit here, just to make some decoration. Now, let's start talking about our GI tract. So please, if you have some questions, yes, you can raise your hand here in the Moodle in the one of the on the screen. So so I put everybody in the off microphone. Okay, so let's start. Here we are going to start today talking about the gastrointestinal physiology. And for that, we have the base of the basic anatomy. We are going to just remark in a few things that are going to be used during this lecture. Number one, we have the GI system. The system we remember that is composed by different organs. And the GI system is going to be divided in GI tract and accessory organs. The GI tract is everything that is the tubing from the oropharynx to the rectus and anus. And so everything that is tubing, so that means the oropharynx, the esophagus, the stomach, the small and the large intestine until the end of the rectum and anus. And the other component of the GI system are going to be the accessory organs. We already know the salivary glands. We are going to mention about what is the content, what is the saliva contains. We are not going to talk the liver today, no gallbladder, neither the pancreas. And but in general, what we are going to talk is about how the GI system is going to modulate and regulate all the secretions of all these structures in order to accomplish the functions of the GI tract. We have ingestion, digestion, absorption, metabolism, excretion, and actually, you can see here, is not including the distribution, because distribution is definitely a part of the cardiovascular system. So it's going through vessels. Okay, so let's start. And here we are going to talk about the layers of the wall of the GI tract. From the esophagus to the anus, the thickness of the wall of the GI tract is about 3 to 5 millimeters. 3 to 5 millimeters is the thickness of the wall of this GI tract. But in this small space in between these 3 to 5 millimeters, we are going to find 4 layers. One is the mucus or mucosa, the submucus or submucosa, the muscularis layer, and the serosa. So how many layers we have? 4 layers. So let's continue. All right, so here just to show the cross section of the wall of the intestine. So we are going to start with the mucosa, and the mucosa are, you can see these foldings, and they are going to have many components. We have the epithelium, we have the lamina propria, where is the actually these cells, the squamous cells, are going to be sloughed off every 3 days. So all the GI tract, the mucus are going to slough off every 3 days, and it's going to change. And it's the lamina propria where it's coming the new cells that are going to replace the ones who are sloughed from the GI tract. And then we have the muscularis mucosae. Muscularis mucosae, please don't, students get confused sometimes. That is actually the muscularis area that is here. And this muscularis mucosae is just belongs to the mucosa. And this muscularis mucosae is a muscle, yes, it's a smooth muscle. And what the function of this muscularis mucosae is to, they have some small contractions that are going to make the, because the mucosa is having up and downs, up and downs, up and downs, so it's a glandular tissue. And in between there's nutrients that are going to be trapped. So the muscularis mucosae, what it's doing is a kind of keep moving and not get stuck in one place. And that is what is the muscularis mucosae that's doing. So here we have the mucosa. Under this, in the mucosa, we are going to have all the glands, all the teeth, all the cells that are going to produce secretions we are going to see soon. The submucosa is under the mucosa, and the submucosa is going to contain especially the lacteal vessels, where they are going to receive the fats that are going to be absorbed in the wall of the intestine. And the muscularis externa. The muscularis externa, we have, this is, if you see here, the pattern of the muscles are slightly different. One here is elongated, and here is going to be like cutted in transverse. Why? Because we have two groups of muscles, the inner, the circular layer, and we have the outer longitudinal layer, that those are responsible for the peristalsis of the GI tract. Not the muscularis mucosae, but the muscularis externa that we call cile, C-I-L-E. So that means circular internal, and L-E means longitudinal external. All right, so let's continue. I'm going to open microphone just in case, because I'm not sure if everybody is listening. Okay. Okay, the microphones are on. Okay. All right, so let's start. The mucosa is going to have a mucosa, submucosa, muscularis layer, and serosa. So those are the four layers. And here we have a comparison of the small intestine and the large intestine. So basically, there's a difference between the between one to another, because the functions are actually different. We have in the small intestine mostly, we have the majority of the absorption of the nutrients, and the remnants of the nutrients are going to be very few when they pass to the large intestine. So the mucus, mostly what they're going to absorb is amount of water. Here we have the mucosa, the submucosa, and the muscularis layer. Here we have, in addition, we have the glands, so the villi, the capillaries, and lacteals. So that is the end of the lacteals. They start in the submucosa, but they are going to end into the mucosa, the lacteal, that are going to absorb the fats. So now the villi, as you know, is like hills up and down. And what is the purpose of this? Is to increase the surface of absorption. I was looking about the area of absorption of the GI tract, and that is about 322 square feet. So that is about 20% of the tennis court area. So that is the area of absorption that we have in the intestine. We have, in addition, goblet cells that actually are mucous cells, and these mucous cells mostly are going to be located in the esophagus, in the stomach, in the duodenum, and in the large intestine. And the purpose of this is to protect against changes of the pH. Submucosa, we have the larger blood and lymphatic vessels. So these are lymphatic vessels, which transport nutrients into the circulation. So as you know, the fats are going to be absorbed, and they are going to go through the lymphatic system. The muscularis layer, we have the longitudinal and circular muscles. If you can tell, if there is longitudinal, the way they contract the muscle is to move forward, and the circular muscles is just used to mix the content in the GI tract. So mostly mixed with the enzymes that we are going to see now. And the serosa is the outer covering of the gut. Okay, so here we have the stomach, here we have the duodenum, and here we have the large intestine. And if you see here, we have the stomach, and the stomach, they have some pits, gastric pits. So there are going to be some undulations of the mucus. Number one is to increase the area of secretion of the enzymes of the stomach. And here in the small intestine, large intestine is to increase the area of absorption. So here we are going to have some general general organization of the GI tract. You see here, this is the mucosa, this is the submucosa, this is the muscle, this is the cile, the circular internal, and the longitudinal external. So here we have what I want to remark are the nervous system. The Meissner and the Auerbach is called the myenteric nerve plexus. So they have two names here. Mostly they call myenteric nervous plexus, but the proper name is the Auerbach myenteric nervous plexus. So what are doing here, this is what is important to remember, and probably for the next midterm, is that the Meissner plexus. Meissner plexus are going to be located in the submucosa, These guys are the ones who are going to be very, very close to the cells of the mucus that are going to send the orders or signals in order to produce the hormones or enzymes that are being made for. So the Meissner plexus is actually connected to the parasympathetic nervous system, and the parasympathetic nervous system is correlated to the acetylcholine. The acetylcholine is going to play a very important role in the GI in the functioning of secretion of hormones. And Auerbach myenteric nerve plexus, if you can see, these are in between the two layers of the smooth muscle. So what is doing this Auerbach myenteric nerve plexus is to produce or make effective the peristalsis. Okay. All right. So let's keep going. So here we have, again, just not to lose the idea here, we have the submucosa Meissner, and we have in between this is the submucosa Meissner, and the muscular layer, we have the myenteric plexus or Auerbach plexus. So plexi is the plural of plexus, and the function is to release digestive juices and peristalsis. Okay, so this guy Meissner is going to make the glands to secrete, and this Auerbach myenteric to contract the intestine. So actually what is playing a role here is the acetylcholine, and the acetylcholine are actually, this is a parasympathetic nervous system, and we have for another side the sympathetic nervous system that is going to release norepinephrine or epinephrine. As you can remember, the balance between the parasympathetic and sympathetic. So when the parasympathetic is increased, the signals, the sympathetic go down. And the opposite, when the sympathetic go up, the parasympathetic go down. So they are going to be opposite. So I was telling my students that actually, for example, parasympathetic is rest and digest, and the sympathetic is fight or flight. So, for example, the rest and digest is defecation, and for example, flight or flight is going to be running. So we cannot do both things at the same time, and definitely that is a proof that one predominantly is one of the systems up, the other go down. Okay, so we are going to have here the myenteric plexus that we already know, that is the Auerbach myenteric plexus, and we have the Meissner plexus that we already mentioned here, that is in relation with the mucus and secrete digestive juices and control gut blood flow. So they are going to have some the vessels are going to be connected here in order to produce some vasodilation or vasoconstriction. So here we have, just I was trying to show you here in this picture. This is an histological cut of the mucus of the wall of the intestine. It could be any part of the intestine. Here we have muscle. Can you see the configuration here? Another muscle configuration here. So here is actually circular, and this is the longitudinal muscle. So those are parallel to each other. So in between of them, we are going to have the mesenteric here in this line, the mesenteric plexus or the Auerbach plexus. All right, so let's start talking about the central, the connection between, or the homeostasis that is related to the nervous system and the endocrine system. So obviously you can tell that the GI tract have the endocrine system where they are going to release hormones, and they are going to have an effect, stimulation or actually inhibition. And that's what we are going to see today. So we start with the vagus nerve. Cranial nerve number 10 is the pneumogastric nerve that is coming from the brain stem, and they go to the respiratory tract, passing through the cardiac, to the heart, and they go to the GI tract. And this is going to be innervated. So the vagus nerve belongs to the parasympathetic nervous system, and that is the guy who is going to release the acetylcholine. And the acetylcholine is going to get into the plexus, and the mesenteric plexus, and they are going to just release the secretions. All right, so this is just a close-up about what we was mentioning. All right, so let's start talking about the GI hormones, and that is to maintain the homeostasis. This homeostasis is going to be related of the ability to make the GI tract functions work properly. So we have the stomach. Let's focus on the stomach. In the stomach, we are going to have actually some cells that are going to be called the parietal cells that secrete the chlorhydric acid. The chief cells that are part, if you see here, if this is the stomach, we have the glands of the stomach, and they go like hills up and down, and these cells, the lining of these mucus are these cells, and these cells are specialized. For example, at the bottom of here, this gastric gland, we have the G cells. G cells are the gastrin cells, or gastrin cells that produce the gastrin. We have the chief cells that is going to produce the pepsinogen, and this is an active enzyme. Pepsi, what is going to do? Digest proteins. Gastrin, for example, is going to stimulate parietal cells that are here. This is the parietal cells, parietal, chief, and G cells, and these, they are going to interact with each other in order to secrete the gastric acid and some enzymes like is inactive that is going to be activated under the environment of acidity. If you can remember, the enzymes are going to mostly work in certain environment. Some enzymes are working in the acid environment, other works into alkaline environments. So these pepsinogen are going to be activated into pepsin when they find an adequate acid environment with chlorhydric acid. Okay. All right. So that is, for example, we have again the parasympathetic nervous system. They are going to go through the pneumogastric nerve. We have an hormone called bombecin, which stimulates the release of gastrin. So they are going to, so if you remember the parasympathetic nervous system, cranial nerve number 10, acetylcholine. Acetylcholine is going to activate the G cells to the gastrin, and the gastrin is going to stimulate the chlorhydric acid to be produced. And this, at the same time, is going to activate the pepsinogen into pepsin. Okay. All right. So we have another functions. For example, these G cells are going to have substance that stimulate the growth of the gastric mucus, and the chlorhydric acid, as we already mentioned, are going to activate the pepsinogen into pepsin. All right, so here we have the gastric pit, and we have the gastric gland. So from here to here is called the gastric pit, and from here to here is going to be the gastric gland. So if you see here, here is going to be the nutrients in this lumen, and in between them we have here some cells. These cells are going to be differentiated and is specialized. At the bottom is actually mostly located the G cells, the gastric, produce the gastrin. Then we have the chief cells here and the parietal cells. Here we have the mucous cells. You see here the mucous cells. These mucous cells are having, some cells are going to produce bicarbonate, for example. Other cells are going to produce just a mucus. And the mucus, as you know, is protective. So the acid never, for example, will be in contact with the mucus because of the presence with the mucosa, because of the presence of this secretion called mucus. All right, so let's keep going with the enzymes. We are going to talk about three main enzymes that are going to be, in the previous one, we talked about the stomach. Now it's turn to talk about the duodenum. In the duodenum, as you can tell, is the first portion of the small intestine, and there's three hormones that are going to have actually main functions here. The CCK, or the cholecystokinin. The cholecystokinin is released by the duodenum wall, the secretin by the duodenum, and the GIP, or the gastric inhibitory peptide, is going to actually produce in the duodenum. So cholecystokinin, what is the function of the cholecystokinin is, number one, to increase the pressure or make the gallbladder contract in order to release the bile. They are going to have contraction too of the walls of the pancreatic duct. Pancreatic duct is going to, they're going to promote the secretion of the pancreatic juice. So cholecystokinin is going to be stimulated when the chyme that is passing from the stomach to the duodenum, they have certain pH, acid, and mechanical contact with the wall of the duodenum are going to produce the cholecystokinin. So the cholecystokinin produce the contraction of the gallbladder for emulsification, and the pancreatic is going to stimulate the secretion of the pancreatic juice at the same time. In addition to that, the cholecystokinin is going to inhibit the gastric acid. Why? Because we don't need it anymore if we have the food, the chyme, already in the duodenum, and the duodenum is, the stomach is going to be empty. That cholecystokinin is going to inhibit the gastric secretion from the parietal cells. We have the secretin. Secretin is produced by the cells walls, mucosa, S cells, and what this is doing too is to stimulate the release of pancreatic juice to neutralize the acidic chyme. It's going to inhibit the chlorhydric acid from the parietal cells, and it's going to decrease the gastrin. That is going to, gastrin, as you know, is going to stimulate the chief cells and the parietal cells too. We have another function is the growth of the pancreatic exocrine glands, so the secretin. Secretin remind me the words to secrete, right? So what is going to secrete is mostly the pancreatic juice. All right, so we have the gastric inhibitory peptide, GIP, is the hormone that is secreted again from the duodenum, and they have two main functions: stimulate the insulin released by the pancreas, that is in addition of what is the digestion of the nutrients, and inhibit the secretion of the parietal cells. if you can tell here, all these hormones that are coming from the duodenum are going to mostly inhibit the gastric acid. So again, I want to repeat that when the food, the nutrients, the chyme is passing from the stomach from the stomach to the duodenum, we don't need more gastric acid. So all the enzymes that are coming later are going to inhibit. So it's actually the normal process of the digestion. So the body knows actually what are the beginning or the end of the secretion of each of them. Okay, so here we have some, for example, the gastrin. The gastrin is going to activate the cheek cells, parietal cells, pepsin, and chlorhydric acid. Then we have here they are passing through the duodenum. In the duodenum, they are going to release the cholecystokinin, and the cholecystokinin is going to stimulate, positive here, the secretion of the bile, contraction of the gallbladder, and secretion of the bile for emulsification, and the CCK is going to stimulate the glands of the pancreas in order to secrete the pancreatic juice. At the same time, we have the secretion. Remember, we will mention secretin is going to stimulate the secretion of the pancreatic juice from the pancreas. Okay, so we have here the GIP. We have the gastric inhibitory peptide hormone that is going to inhibit the secretion too of the gastric acid. So everything that is coming after the stomach, all these hormones are going to have the similar function, that is to decrease the gastric acid, that we don't need it anymore if the chyme is already in the bile, in the gallbladder. All right, so let's talk about I want just to open microphones. Let me see if I can open. Sarah, can you hear me?
Yes, I can hear
you. Joe, can you hear me? Any questions so far?
Yes.
Okay. All right, so thank you. So let's continue with the saliva or salivary uses. We have here, as you remember, we have the three pairs, right? The parotid gland, the sublingual, and the submandibular gland. So the parotid gland is the largest salivary gland. We count. We have a pair, right and left, and here you can see the duct. This is an exocrine gland, that you can tell because they have ducts. And this exocrine gland, for example, in the parotid gland, is going to end in the top of the second premolar tooth. So if we open our lips, we can see upper in the gum, close to the second premolar tooth, there is an opening. We can see that in the mirror, and that is the exit of the parotid gland. So parotid gland is characterized. We have actually, first of all, the saliva is having many components. That we produce about 1.5 liters of saliva per day, and the pH is going to be a little bit from alkaline, in the range alkaline, to a little bit acidic. And we are going to talk about if the isotonicity of the saliva, and then become hypotonic in the next slide. So we have the submandibular glands, that is 70% of the overall saliva. So this is the one who produce they have moderate viscous consistency. Parotid glands are going to secrete about 20%, and mostly is watery. And the sublingual contributes about 10% of the saliva that is very viscous. Okay, saliva concentration we have initially is isotonic. The saliva is isotonic, means the secretion of the saliva is going to be equal of the blood, and then become hypotonic. Why is becoming hypotonic? Ducts are impermeable to water, and more ions are reabsorbed, sodium chloride, than secreted. So saliva becomes hypotonic. And what is this? Because that is a way to protect. So if there is hypotonic, fluid is not going to escape more from the body, and that is going to protect us against from some severe dehydration. Saliva enzymes, we have the amylase and the lipase, amylase and a lipase. The lipase is similar as the pancreatic lipase, and is the same as a pancreatic amylase here. So the amount of amylase secreted between the pancreas and the saliva and the salivary glands are actually similar amount. But the lipase is releasing less quantity in the salivary glands and higher, much more higher in the pancreas. So that's why when somebody has pancreatitis, they don't take as a parameter the amylase, because if you know pancreatitis, you have amylase and lipase elevated. But if you don't, the most important of these enzymes to make diagnosis of pancreatitis is the lipase. Why? Because if you take amylase as a parameter, you don't know is this coming from the saliva or is coming from the pancreas. But it's very high elevation of the lipase. It's very likely that the lipase is going to be coming from the pancreas. So that's why we use as a parameter for pancreatitis. We have other secretions in the saliva. Saliva, we produce a liter and a half, so like 2 bottles of wine in a day of saliva. And these their secretions, we have, for example, the glycoproteins that are going to have a function to lubricate and protect the buccal mucus from food and abrasions. And of course, from dryness. You know, dryness is one factor, important factor that can produce some abrasions on the skin. Lactoferrin, that is another substance that is going to help as a bacteriostatic. Lysosomes break down bacteria and offer protect iron against infection. And of course, the immunoglobulin A. Immunoglobulin A is going to be in any secretion of the body. No, and any secretion of the body is the immunoglobulin A that are going to protect against infections. One thing I want to mention before I forgot is the amylase. They have another name that is called the thiolin. Thiolin, well, I'm going to spell it. I cannot write down here. Let me see if I can. No, I don't want to mess it up. I don't want to lose the screen. All right, so let's keep going. Swallowing on deglution. Bolus from the mouth into the esophagus is a reflexive action. So it's a reflex. We are going to see, we can control voluntary the swallowing at the beginning, but then later on that is going to work automatically through the smooth muscles. Since we have, so as you can tell, swallowing is going to involve more voluntary and involuntary muscles. We have the sensory impulses, that is actually the glossopharyngeal and the vagus nerve. We have the motor impulses that produce through the efferent branches, that is make the action of the deglution itself, the glossopharyngeal, the vagus nerve, and the hypoglossal nerve. So we have 9 and 10 efferent, and efferent we have 9, 10, and 12. So the glossopharyngeal is the one who gives you the taste of the taste of the food, and we have the uh, and the vagus nerve is going to stimulate the acetylcholine, and the hypoglossal is the one who actually make the movement of the tongue and the pharyngeal muscles. Okay, swallowing voluntary during ingestion. The tongue, I want just to show you here something in this picture. So we have the swallowing process, and the swallowing process here we have the palate, here we have the uvula, These uvula are going to have a function, and we have here the epiglottis that is on the top of the larynx, and here we have the respiratory tract, and posteriorly we have the esophagus, the GI tract. So what happens is when you start to swallow, this is the bolus here in yellow, they are going to the uvula we call the bell behind the oropharynx, are going to retract, and they are going to close the area so the food cannot go into the nasopharynx. They will not in the nasopharynx. This is the nose. You can see the nose here. So that is the function of the uvula. And then when the bolus is passing, the uvula keep closing the nasopharynx opening, and they're going to close to the larynx that is connected to the trachea. And actually the bolus is going to pass directly into the esophagus. All right, so esophagus, we have, it's about, when you swallow something, it's going to take about 13 seconds to go from the oropharynx down to the esophagus. The esophagus measures about 25 centimeters, so about a foot long, and 13 seconds is going to take from the mouth to the stomach. And the esophagus is going to be just not that as more thicker than your index finger. And this muscle, this esophagus has a muscle. We have 1/3 superior third portion that is mostly a skeletal muscle, the wall of the esophagus, that is somehow voluntary. And the 2/3 distal portion of the esophagus is totally involuntary. So we have two sphincters. We have the upper esophageal sphincter, and we have the lower esophageal sphincter. The upper esophageal sphincter is going to relax at the time that is going to pass the bolus into the esophagus, and is going to close behind. So here we have the circular and the longitudinal muscles working in the esophagus, and you can tell we have the plexus that are going to make a contraction of these muscles. Okay, so here is going to be the peristaltic contraction is going to be by the esophagus, generated by the acetylcholine released by the cranial nerve number 10, and that is going to push forward the bolus to the stomach. We have then the lower esophageal sphincter are going to, excuse me, all right. So the lower esophageal sphincter is going to be, is going to contract at the rest. And that's what it's doing is to prevent the gastric reflux. So there is, I would like to mention here about what is GERD, the gastroesophageal reflux disease, and the gastritis. So there is two different things. The gastroesophageal reflux disease is gastric acid going into the esophagus. Where is the problem? The esophagus, period. And the gastritis is the inflammation of the lining of the stomach that is increase of gastric acid. So that is the difference between them, both of them. All right, so we have other hormones. We have the gastrin. The gastrin is going to stimulate the increase the tone of the lower esophageal sphincter. So the lower esophageal sphincter is in the boundary between the esophagus and the stomach. So obviously it's very wise, right? So gastrin, what it's doing is increase the gastric acid, and at the same time it's going to increase the tonicity of the lower esophageal sphincter. So that is not going to allow the gastric acid going to the esophagus. The esophagus only can stand pH about 7. Meantime, the stomach, we have pH between 1 to 4, average pH 2. So actually, that's a good way to maintain the homeostasis of normal mucus of the esophagus. We have the cholecystokinin and we have the secretin that is going to decrease the tone of the lower esophageal sphincter. Stomach, we have a bolus reach the stomach, and that is going to be called at this moment chyme. Stomach, we have as you can tell, you remember about a little bit about anatomy. We have the fundus and the body, and the antrum. The fundus is on the top, the body is the major portion of the stomach, and the antrum is at the bottom. We have the parietal cells are more concentrated in that area, in the fundus and the body. we are going to see that parietal cells produce the chlorhydric acid and the intrinsic factor. I'm going to stop a little bit here about intrinsic factor because there's many students who sometimes think that the intrinsic factor is gastric acid, and it's not. The intrinsic factor is a glycoprotein. It's a protein associated with the glucose. But the important thing is to differentiate that the intrinsic factor is not chlorhydric acid. And this glycoprotein of the intrinsic factor, as you remember, is the one who link with the vitamin B12. And the vitamin B12, in this case, can be absorbed in the distal ileum of the small intestine. So function of the parietal cells in the fundus of the body. We have the chief cells. The chief cells have two functions. The one that we remark mostly is the pepsinogen that is going to be activated with the presence of gastric acid. And the activation of pepsinogen is going to lead into pepsin. And the pepsin is going to do the digestion of the proteins. All right, so the mucus is going to be released in order to produce to protect the lining of the stomach. We have in the antrum. In the antrum, we have two cells that are going to be the gastrin and the somatostatin. Somatostatin, I call this as a referee, the referee of all the GI tract, because everything that is stimulated and released, the somatostatin, what is going to do is the inhibition of all these secretions. So it's going to inhibit the secretion of pepsinogen, is going to decrease the secretion of chlorhydric acid, is going to decrease the secretion of the intrinsic factor. All right, so other types of the cells that are really important are the enterochromaffin cells. The enterochromaffin cells are actually, they are going to secrete many substances, for example, serotonin, histamine. The histamine, what is histamine? If you remember, in the body we have two types of receptors of histamine. Histamine 1 and histamine 2. Histamine 1 is the one who makes you release histamine when you sneeze. When you sneeze, I tell my students, I said, histamine, 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 H1 when you are sneezing. But in the GI tract, we have H2. These H2 receptor are going to release histamine that is actually going to combine with a gastrin, and this gastrin at the same time together they are going to stimulate the parietal cells to produce chlorhydric acid. Okay, so let's keep going. So here we have the gastric acid formation. pH is between 1 to 4, produced by the parietal cells. The hydrogens is generated by the reaction of carbon dioxide and water. So that is in the side of the blood. So the hydrogens are going to be secreted then into the gastric in exchange of potassium through the ATPase hydrogen potassium. Then the bicarbonate is absorbed in the bloodstream in exchange for chloride. So that is what we call the alkaline tidal. The alkaline tidal. The alkaline tidal make your blood more alkaline because this bicarbonate, in exchange of chloride, bicarbonate enters into the bloodstream, and that is going to make us feel slow down a little bit, sleepy at the time after meals. So that is what we call the alkaline tidal. All right, so so I will go into. I have a chart for you that are going to be very helpful, but I'm going to go at the end of that slide. All right. So here we have the for example, the Greyer curvature. Here, this is the Greyer curvature. We have some what we call pacemaker. This pacemaker are going to have they are going to have, for example, is going to produce a contraction of a portion of the stomach and a contraction of the lower portion of the stomach. So we have a slow closure is the time that is going to promote a slow closure of this area because the waves that are going to trigger out contractions are slow. So they have more time in order to actually the bolus enter into the stomach. And here, at the same time, it's fastest where the pyloric area are going to start contracting, and they are going to allow waves. But these waves are very short. Why? Because the depolarization are faster, so are less time to be open. But here it's going to be in the upper, it's going to be more time opening, and here it's going to be less time opening. So that is how at the beginning of when the chyme gets into the stomach are going to make effective the entry and some exit of the. We need to make a slow the pass of the food of the chyme from the stomach to the duodenum, and that is happening when you have higher, more fast depolarization. This faster depolarization, slower depolarization. Okay, so here we have more volume of chyme into the duodenum. So how the chyme is getting into the duodenum? That depends on three things. More pressure gradient between the antrum and the duodenum. So there's more pressure of the mechanical pressure from the stomach into from the difference between stomach and duodenum. That is going to for this gradient pass the food from one place to another. Pyloric relaxation and the cholecystokinin that influence in the gastric emptying. So they have some actually affect the contractility of the stomach, and that is going to produce the evacuation of the food into the duodenum. All right, so motilin is another hormone that is the contraction initiated by the stomach to keep materials moving forward into the gut and prevent stasis. So this is actually motilin stimulate the contractility of the stomach. And here we have in this chart we have something really important. When you have the food that is isotonic, and mostly isotonic or close to isotonic are going to be the carbohydrates and proteins. Slow is going to be the hypertonic high concentration is going to be fat. So what we have here, the pH is going to be mostly neutral, and the pH here in the fat are going to be low. So what does that mean? That means that here when we have the gastric emptying is going to be slow when you are eating fatty meals. That become hypertonic, and the pH start to decrease. So that means more secretion of gastric acid. What is telling you this is that gastric emptying is going to be slower when you eat fat. Applications of this is when you have, for example, some gastritis, you produce gastric acid, right? Or for example, you have some ulcer that produce acidity. So if you eat fat, that is going to, the emptying is going to be slow. So that means that you have more time the food in the stomach, and the stomach obviously is going to start secreting more gastric acid. So it's bad to eat fat if you have ulcers or if you have gastritis. So that's why we need to prevent that kind of foods. Okay, so here pancreatic enzymes. We have the proteases, is the general name for the trypsin, the carboxypeptidase, chymotrypsin, that are going to, all of these are going, trypsin, P, protease, peptidase, protein, trypsin, again, protein. So all are proteins. Amylase are going to digest the carbohydrates. Lipase are going to digest fat, and the nucleotides are the nucleases. So number one, what I want just to remember here is this. We mentioned that the enzymes, they have some area of some pH where they can work. For example, these pancreatic juices or pancreatic enzymes are inside the pancreatic juice. The pancreatic juice is all these enzymes plus water plus bicarbonate plus electrolytes. So this bicarbonate is making the pancreatic juice very alkaline, pH 12. So these protease, amylase, lipase, and nuclease cannot be activated when they are in alkaline environment. So when they're passing through so that's why the pancreas is not auto-digest for these enzymes. So it's when the pancreatic juice go out from the through the pancreatic duct or Wilson duct into the second portion of the duodenum is where the chyme, we are going to find the chyme that is coming with a lot of acidity. So that is when the acidity of the chyme and the pancreatic juice, the alkaline, are going to neutralize, and these enzymes are going to find an environment where they can actually be active. And this environment is when it is close to neutral pH. Peristalsis, peristalsis we have is peristalsis. Where start the peristalsis? Peristalsis is going to start since you are actually swallowing. When you swallow, it's like if you shake the blanket of your bed. If you shake the blanket is going to make some waves, right? That are going to, as the waves are going to go forward. So when you swallow, all the muscles are, it's like you're shaking with your hands, and the blanket is going to be the esophagus. And that is where they're going to stimulate the peristalsis, the beginning of the peristalsis, and that is going to be transmitted from, as a blanket, let's put it that way, from the esophagus to the stomach, to the small intestine, and to the large intestine. At the beginning of the lecture, you see that video where the peristalsis is moving forward, and that is going to be high stimulation when you eat. When you eat, you are swallowing, 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 and swallowing. Normally we swallow all day, right? So we have about 600 times swallowing a day. I don't know who counted, but definitely that's what I read, 600 times in a day. But during the meals is where you swallow more. So the peristalsis is going to be more activated in that moment. So the bolus, chyme, and then is going to be the fecal material, is going to fill up the ampulla of the rectum, and that will produce the stimulus of defecation. All right, so defecation, we have two sphincters, the sphincter, the external and the internal sphincter, and the internal sphincter is not under our control. It's only the external anal sphincter, and that is controlled by pudendal nerve coming from the lumbosacral area. A Valsalva maneuver is when you, for example, or somebody go to the bathroom and push, and what you push is you close the glottis, you don't exhale, so you maintain the air inside, and that is going to increase the intra-abdominal pressure. This intra-abdominal pressure is going to help in order to make the process of defecation. All right, so here I want to show you some. I was just doing this in my in the few minutes ago. I'm going to just sorry, Michelle, go. They are going to summary of the glands and cells of the esophagus, stomach, duodenum, and the colon. So we have here esophagus, for example. We have cells that produce mucus. We have the stomach. We have the mucous cells that produce histamine, mucus, another pepsinogen, gastrin, chlorhydric acid, and bicarbonate. The duodenal, we have two group of cells, the Brunner cells and the Lieberkühn cells that are like crypts of Lieberkühn, and this is the duodenum and small intestine, and that is where you're going to secrete the cholecystokinin, secretin, and other hormones. And the colon, we have mostly these two cells that produce mucus and bicarbonate. And here, please, I want just to show you here, this is the gastric glands, and here we are going to show you here, this is the pits and this is the gastric gland. So here we have the G cells, the chit cells, parietal cells, mucous cells. Mucous cells produce mucus, bicarbonate, parietal cells, gastric acid. Chit cells are going to produce the pepsinogen, and the G cells, the gastrin. So let's start doing, we have who is the ones who stimulate all these cells are going to be the cranial nerve number 10, the pneumogastric nerve or vagus nerve. And what is going to do this is to stimulate the gastrin. The gastrin, where is located in the stomach. From gastrin cells, Gastrin cells produce gastrin on the stomach. And here we have the G cells, just to visualize that. What is doing the gastrin cells? The gastrin cells are going to stimulate the chip cells. We have the chip cells here that are going to be in the stomach too, and they are going to produce the pepsinogen. Then the gastrin, at the same time, these gastrin cells are going to stimulate the parietal cells are here that are going to produce the secretion of gastric acid. Then we have this gastric acid that are going to, the pepsinogen are going to activate the pepsinogen to produce the pepsin. Pepsin, as you remember, is the enzyme that produces the digestion of proteins. Then we have the histamine. The histamine is going to be, so if you remember the histamine, some medications, for example, we have the ranitidine, cimetidine, the famotidine, and these, what they are doing is to block H2 receptors. They last about 12 hours of effectivity. Here, just to mention here, the chlorhydric acid that is going to secrete protons or hydrogens into the lumen. We have, for example, the Prilosec. We have omeprazole, all the solids, omeprazole, that are going to be active for 24 hours, and that is going to inhibit the proton pump that secrete hydrogens into the lumen. All right, so in blue here, so all these guys are going to be stomach. So when the food on the chyme is passing to the duodenum, what is coming? Duodenum is going to start secreting, and in blue means that they're going to inhibit the secretion of gastric acid. Secreting at the same time, what it's doing is secrete what is useful at that moment. In this case, is going to increase the secretion of pancreatic juice. The secreting increase the secretion of pancreatic juice and decrease the secretion of gastric acid in the stomach. The somatostatin are going to do the same. It's going to secrete more substance from the pancreatic juice and it's going to inhibit the gastric acid. The secreting at the same time is going to inhibit the gastrin, and the gastrin diminish the stimulation of pepsin and gastric and chlorhydric acid. So everything is correlated. The cholecystokinin is going to decrease the gastric acid. Then we have remember the parasympathetic, the cranial nerve number 10, are going to stimulate the secretion of the secretin, cholecystokinin, and somatostatin. And actually that is a cycle that is going to be repeated after meals. All right, so I guess we finished just on time. And I want to thank you for for attend to this webinar. And I would like to hear if there is some comments, please, or some questions. Sarah?
Oh.
Sarah, can you hear me? I see.
Yes, Dr.G. Sorry, I had to mute my microphone because of my kids.
Oh, okay, that's okay. So we finished the webinar. Is there any questions, Sarah?
No, so far no.
Okay, so I hope you enjoy the lecture as I did too. Thank you.
It helps. It helps a lot. Thank you.
Sure. Thank you.
Well, thank you very much.
And Joe, any question? Everything is okay?
Yeah. No, it's okay. Thank you.
All right, my friend. Thank you so much.
Thank you.
All right. So
yeah. Have a good night.
All right. Have a good night, and I will see you next Sunday.
See you then.
See you then.
See you then.
Thank you. Bye bye.
Bye bye.